Good evening, everyone. So today I'm going to discuss about COVID-19 therapeutics, where we stand now. So first of all, we are going to discuss about the therapeutics which is used to treat non-hospitalized patients. And now means this presentation had been prepared by 20 February 2022. So why this time is important? Because of this mantra, and which is very relevant to COVID-19 therapeutics evolution. That is Parivartanema Sthiramasti. The only constant is change. So we are going to discuss what are the treatment options for high risk non-hospitalized mild to moderate COVID-19 patients, which treatment are preferred and why, what are the treatment guidelines available, and what could be the future directions in outpatient therapies. So this is the treatment across the COVID-19 spectrum. Asymptomatic or pre-symptomatic COVID means there is positive SARS-CoV-2 by COVID-19 RT-PCR test, but no symptoms. Mild illness means the patient have mild symptoms like fever, cough, or change in taste or smell. And in this Omicron pandemic, the mild illness means there are some involvement of upper respiratory tract, including running nose, sneezing, some scratchy sensation in throat. But the point to be noted, no dyspnea. In mild illness, that means there should not be any dyspnea. Now, what is moderate illness? Clinical or radiographic evidence of lower respiratory tract disease. So here the involvement is, it already occurred in the lower respiratory tract, but the oxygen saturation is more than equal to 94%. And what is severe illness? That means the oxygen saturation is below 94%. There is tachypnea, respiratory rate is more than 30. Lung infiltrates that involved more than 50% of the lung field. Apart from that, the critical illness means when the patient presented with respiratory failure, shock, and multi-organ failure. So what happened when just the symptoms is beginning, or just prior to the symptoms beginning, there is the highest viral replication rate, and we can see the virus replication reach at its peak at around the onset of illness, onset of symptoms, mild symptoms. So here, and then gradually the viral replication goes down. And generally what happens when the patient present with severe illness, it is due to the hyperinflammatory state. So inflammation starts from middle of the moderate illness, and it goes at its peak when the patients become severely ill. So that is the place, that is the zone where the inflammatory mediators are coming up in a very high quantity. Now, just considering the pathogenesis, if we just think about the potential treatment strategies, so initial few days, we should start with antiviral therapy that can give some sense. So antiviral therapy, if we start delayed, so that means already the viral replication done, the inflammatory stage sets in. So there is no way to get benefit from this antiviral therapy. And this initial period, when the viral replication period is ongoing, there is the role of different types of antibody therapy, including different monoclonal antibodies. And whatever the anti-inflammatory therapy we have, that has a definite role when there is inflammation is sets in. So with the beginning of the inflammation and at the end of the viral replication, there is a place, depending on the symptoms, we need to start anti-inflammatory therapy. That means the steroids, that means the anti-IL-6 maps like tocilizumab, or the JAK-STAT inhibitors like baricitinib. So this is a very important diagram we need to understand when we are talking about different therapeutics. And as today we are going to discuss about everything about the everything on outpatient basis therapy of COVID-19. That means we are going to deal with mild illness and moderate illness patients. So the focus will be mostly how we can tackle or how we should address that viral replication phase. So in this beginning part, there is not that role of inflammatory therapy, anti-inflammatory therapies. They have their role when patient requires hospital admission with severe illness, and there is the role of at that time the oxygen saturation is going down below 94%, and we need steroids, we need baricitinib, we need sometimes tocilizumab. As I am talking one thing, just that baricitinib and tocilizumab simultaneously, one thing we all should remember: in one patient who took baricitinib, we should not use tocilizumab, and vice versa. They should not given together concomitantly in same patient. That is a very important message I want to share with all of you. Now coming to the pathogenesis, how the virus enters into our body. They attached with the ACE2. Here you can see the ACE2 receptor and then internalized. So here we need something, because this ACE2 and this spike protein, they have some interaction. If we have some antibodies, monoclonal antibodies more specifically, which can block this attachment, which can block this spike protein and ACE2 interaction, that will give some good things. And we have anti-spike monoclonal antibody. There are different anti-spike monoclonal antibody, but as of 2022, there is, I want to name only this monoclonal antibody here, sotrovimab. And after that, when the virus internalized the viral RNA, we need the translation of viral proteins. So there will be polyprotein chain development, and further there will be proteolysis. And this proteolysis is a very important step, because that will help for, or that will help to prepare for the RNA replication of particular viral proteins. So for this step, this proteolysis step, the SARS-CoV-2 needs this enzyme, that is a protease or main protease enzyme. And to block that, this protease, we have nirmatrelvir. And to increase the bioavailability of the nirmatrelvir, we need one pharmacokinetic enhancer. And what is that pharmacokinetic enhancer? The ritonavir, which blocks the CYP3A4 and increase the concentration of nirmatrelvir. So nirmatrelvir is a protease inhibitor and ritonavir is a pharmacokinetic enhancer. Then the fourth step, that is the RNA replication phase, and for that we all know RDRP, or RNA dependent RNA polymerase, is an important enzyme, and we need some drugs to block that, and for that we have Molnupiravir and remdesivir. So these are the area where we should focus to develop different antivirals, and we are really fortunate that our scientists had developed these molecules which can block SARS-CoV-2 at different levels. So as we are talking about monoclonal antibody, the infectious disease spectrum was as a whole a neglected area, if we can see from 1990s and onwards. So it is only this 2019 to or rather 2020 to 2022, these 2 years, there is lots of monoclonal antibody is coming up in the field of infectious disease. And as we are talking about anti-SARS-CoV-2 monoclonal antibodies, first of all, we should not compare directly all those molecules with this type of data, but I just want to put the different relative risk reduction here to understand or to get a knowledge about the efficacy of each monoclonal antibodies that is available. So these are phase 3 placebo-controlled trials in non-hospitalized patients with mild to moderate COVID-19 and more than one risk factor for severe disease. So what are the maps? First of all, the combination of bamlanivimab and itesevimab, they reduce the relative risk reduction in terms of hospitalization or death is 70%. For casirivimab and imdevimab, they also has a relative risk reduction of 70% of hospitalization or death. These all are the primary outcome of those trials, of those phase 3 trials. And sotrovimab, which has a 85% relative risk reduction in terms of reduction in hospitalization or death. Among these, only we have casirivimab and imdevimab. So as we are talking about sotrovimab, why we are talking about sotrovimab after this Omicron pandemic, we will going to discuss, not the others. The another important message on this sotrovimab is another route of administration is being explored, that is intramuscular sotrovimab. So there was a trial, COMET-TIL phase 3 randomized control trial of intramuscular versus intravenous sotrovimab 500 milligram in high risk non-hospitalized adults or adolescents up to 7 days after symptoms onset. So again, this duration is very important, 7 days. So they include almost 1,000 patients, 983 patients. So progression to hospitalization or death, 2.7% in IM arm and 1.3% in IV arm. So it was seen that intramuscular sotrovimab is non-inferior to intravenous sotrovimab, but yet it is not authorized by US FDA, IM delivery. But hopefully some more evidences will tell us whether this can be used as an option, because obviously compared to the intravenous sotrovimab, if we have this intramuscular sotrovimab, we can use this drug more frequently as a OPD basis. And also the other monoclonal antibodies like casirivimab and imdevimab, which is available in India, they also need to be given over infusion. But there is another route of administration is available for them also, subcutaneous route, but it is not that much used in our country. So another MAP cocktail, that is tixazevimab and silzazvimab, they are authorized for pre-exposure prophylaxis. It is not post-exposure. Already we know there are a good amount data regarding that post-exposure prophylaxis of COVID-19 with casirivimab and imdevimab. They had a published randomized control trial also, which suggests post-exposure prophylaxis can be given, can be obtained by that casirivimab, imdevimab map cocktail. But this is very interesting, that pre-exposure prophylaxis concept. But it is important to understand the background. This drug should be administered concomitantly, and the dose is 150 milligram each by intramuscular injection for pre-exposure prophylaxis of COVID-19. Who are the beneficiaries? The persons more than 12 years of age and weight more than 40 kg have either a history of severe allergy to specific vaccine. Maybe it could be a Stevens-Johnson syndrome with first dose of Covishield or Moderna or Pfizer vaccine, or a severe life-threatening anaphylaxis happened with first dose. So they are the eligible patient for this map combination, or moderate or severe immunocompromised patient. So the patient has some degree of immune compromised nature. For that, the patient needs some extra this pre-exposure prophylaxis. And this is important also to note, this drug should be redosed every 6 months. So regarding that immunocompromised or severe immunocompromised patients, these are the list of patients they are considering. This is the US FDA approval. So we can see it starting from advanced or untreated HIV infections to receipt of CAR T cell therapy or hematopoietic cell transplant within the previous 2 years, or active treatment for a solid tumor or hematologic malignancy is ongoing. Any use of immunosuppressive therapy after a solid organ transplant, or patient has an active treatment with other immunosuppressive agents or immunomodulatory drugs, could be corticosteroids more than 20 milligram per day prednisolone or equivalent dose of prednisolone, or any other TNF alpha inhibitors. So these are the patients who are considered to be as a severely immunocompromised patients and eligible for pre-exposure prophylaxis. But what is important to note, they are not a substitute for COVID-19 vaccination. So as we can see, we are talking about sotrovimab frequently. We are not talking about casirivimab imdevimab combination. I had a previous presentation on casirivimab imdevimab combination maybe 3 months back, when I had just uttered the name of sotrovimab. But today I am repeatedly talking about sotrovimab and trying to dissect different data on sotrovimab. Why this diagram is suggesting like that? Why the discussion on sotrovimab is important? Why the discussion on tixazimab and silzavimab is important? Though they are not available in India, they have emergency use authorization in USA by US FDA, because after this Omicron pandemic, which has more than 50 amino acid changes, at around 32 substitutions in the spike protein. So spike protein is the source where all the or the spike protein is that particular target where all those monoclonal antibodies are going to bind and inactivate the virus. But if the virus has done more than 30 substitution in the spike protein, so the monoclonal antibody will not do any harm to the Omicron variant of SARS-CoV-2. So that is why this list is important. And we can see the IC50 value was rise so much from 14.4 to 5,000 in Omicron in case of casirivimab and imdevimab, which was in case of Delta, it was only 14.4 or 25.6. So except this sotrovimab, which has allowable IC50 value, and that tixazimab and silzavimab, all the other monoclonal antibodies IC50 increased more than 5,000. But this paper is again alarming. You can see here the Omicron variety BA2, which is already come up in some of the countries, and they had a research on that. And it is very important to note that even tixazevimab and sulzavimab and sotrovimab, their IC50 value becomes more than 5,000 here. So most probably after 2 months or 3 months, if I have another presentation on SARS-CoV-2 therapeutics, I will not going to talk much more about this drug sotrovimab. We don't know. This is a very recently published paper. There is the reference you can see. So that is why we need something which is not directly acting on the spike protein, because maximum mutation is happening in that particular spike proteins. So that is why we need to understand few small molecule drugs which are anti-SARS-CoV-2 viral agent. So SARS-CoV-2 protease inhibitor nirmatrelvir we are going to discuss today now. So SARS-CoV-2 polyprotein that is cleaved by viral main protease enzyme at 11 sites, and these non-structural proteins formed, that is essential for further viral replication. So this protease is inhibited by nirmatrelvir. So inhibition of the SARS-CoV-2 3-CL protease renders the protein incapable of processing that polyprotein precursors and ultimately prevent the viral replication. So we need some pharmacokinetic enhancer for nirmatrelvir, and that is age-old antiretroviral agent ritonavir. It inhibits CYP3A4, so the nirmatrelvir bioavailability will be increased. And the combination of nirmatrelvir and ritonavir, generally it is available as a co-packaged formulation, is known as Paxlovid. So the dose is 300 milligram nirmatrelvir. So there is 2 150 milligram tablets of nirmatrelvir with 100 milligram ritonavir. So 1 tablet of ritonavir, with all 3 tablets to be taken together at morning and at night. So twice daily for 5 days. And this is also very important to note. This 5-day treatment course of Paxlovid should be initiated as soon as possible after a diagnosis of COVID-19 has been made and within 5 days of symptoms onset. So this is very important. If we delay, then the viral replication phase will be over and there is no role of this Paxlovid. So we need to initiate the therapy as early as possible within 5 days of symptoms onset. By this, we can see how this Paxlovid is available. So here you can see the aim dose, 2 nirmatrelvir and 1 ritonavir, aim dose and PM dose like that. And there are some clinical pharmacological considerations. If eGFR below 60 but more than 30, then instead of 2 tablets of nirmatrelvir 150 milligram, we should take 1 tablet of 150 milligram nirmatrelvir along with 100 milligram of ritonavir. Along with, it is also important to consider if the eGFR is less than 30 and the patient has Child-Pugh score C, so severe hepatic impairment, we should not use this drug. It should not be co-administered with amiodarone, rifampicin, rivaroxaban. Dose reduction or monitoring is important when we are using or the patient is already on different calcineurin inhibitors. The patients who are on atorvastatin should be stopped. Rosuvastatin can be continued because it is not metabolized by CYP3A4, whereas atorvastatin is metabolized by CYP3A4. Rosuvastatin is metabolized independent of CYP3A4. So this is a very recent study published just 4 days back about Nirmatrelvir. So what is the message from that? So there is an 89% relative risk reduction. So treatment of symptomatic COVID-19 with Nirmatrelvir plus ritonavir resulted in a risk of progression to severe COVID-19 that was 89% lower than the risk with placebo without any safety concerns. So this is a very important message to take. And here also important area regarding this Nirmatrelvir is the viral clearance. So when treatment was initiated within 3 days after symptoms onset, there is a decrease in viral load at day 5 by 10 times more than the placebo. So this is very interesting, very promising. So if we use early this molecule, there will be a more than 10 times decrease in viral load. And if the viral load is more, that means more than 10 to the power 7. So there will be more reduction. So this is a very important drugs which could help us if we use this drug early. But unfortunately, yet we don't have this drug in Indian market for our Indian patients. It is not available. Hopefully our drug regulators will will explore the data, and then we can get emergency use authorization of this combination too. Now coming to another drug, that is Molnupiravir, which is a oral ribonucleotide prodrug, generally converted to an active form to that beta DN4 hydroxycytidine, short form NHC. This inhibits SARS-CoV-2 replication by inducing the RNA mutagenesis. So they induce RNA mutagenesis in the virus, and accumulate multiple mutations if happen. So that accumulation of multiple mutations beyond threshold in that particular viral genome is also known as viral error catastrophe, and that causes significant impairment or complete loss of viral replication. So there is two mechanisms of Molnupiravir. First of all, there is an incorporation, and that leads to mutagenesis. So again, 10 days back, this was published, the Molnupiravir trial, and also known as the Move Out trial, including 1,433 patients, non-hospitalized, unvaccinated adults with mild to moderate COVID-19 were included. One or more risk factor for severe disease, symptoms onset within 5 days of study randomization, and they are randomized to Molnupiravir 800 milligram. So that means 4 200 milligram pills. So each pill is 200 milligrams. So 4 pills morning and 4 pills night, versus placebo for 5 days. Duration of treatment is 5 days. So interim analysis was published, which suggests there is a 48% reduction in hospitalization or death, but final analysis with 1,408 patients, it suggests 30% reduction in hospitalization or death. So 9 deaths occur in placebo group and 1 in the Molnupiravir group. But one concern is important, and that is mutagenicity. Cost is not only the concern with Molnupiravir. Money is, yes, we know that Molnupiravir is a costly molecule, but M for M means not only the money is important, here the mutagenicity is an important concern. And this paper we can read, published in Journal of Infectious Disease, which had shown that beta DN4 hydroxycytidine inhibits SARS-CoV-2 through lethal mutagenesis for that particular virus but it is also mutagenic to mammalian cells. So hypoxanthine phosphoribosyl transference gene mutation assay. This is an important assay method to understand the mutagenicity, done in Chinese hamster ovary cells that exposed to NHC for 32 days, and that study had suggested that mutagenicity is positive. But short-term studies in vivo rodent assay or a pig assay or a rat micronucleus assay, they not found any evidence for mutagenicity. So ultimately, the FDA, the latest, their address was like that, based on the weight of evidence, including negative in vivo findings, as well as the short-term use, that means 5 days, and the conclusion based upon the expert input. So it's expert input here. The risk of genotoxicity following treatment with Molnupiravir is low. So there is a risk of genotoxicity, but it is low. So we need to be very cautious while using this drug. So who is authorized to receive Molnupiravir? According to FDA, the adults with mild to moderate COVID-19 at high risk for progression and less than 5 days of symptom onset, only if, this is very important, only if other treatments. What are the other treatments? That means the Paxlovid, that means the Sotrovimab, not accessible for clinically or that is not clinically appropriate. So there we can use Molnupiravir according to US FDA. Not recommended in pregnancy, not authorized in children. Why? It could affect the bone or cartilage growth. And last two lines are very important. Females of childbearing potential should use a reliable method of contraception for the duration of treatment and for the 4 days after the last dose of Molnupiravir. So 4 days after the last dose of Molnupiravir, they use adequate contraception. And for males of reproductive potential who are sexually active with females of childbearing potential should use a reliable method of contraception during treatment and for at least 3 months. This is very important to note again, 3 months after the last dose. And this is another important study, very interesting study. We are using remdesivir in our country, but this remdesivir was used in non-hospitalized patients. So among non-hospitalized patients who were at high risk for COVID-19 progression, a 3-day course of remdesivir had an acceptable safety profile and resulted in an 87% lower risk of hospitalization or death than placebo. So there is a 87% relative risk reduction. So this is also known as PINETREE Trial. So what is remdesivir? They are nucleotide prodrug. They inhibit viral RNA polymerase and ultimately acts as a chain terminator. And FDA approved for treating hospitalized patients with COVID-19 pneumonia. So it is not yet approved by FDA for non-hospitalized patients. But this RCT, this PINETREE trial, had shown this is also effective in non-hospitalized high-risk patients who are unvaccinated. And the symptoms, from the symptoms onset, it is less than 7 days. Remdesivir IV infusion was done for 3 days versus placebo. This trial was stopped early due to some administrative issues, not due to scientific reasons. So we can see here the hazard ratio is 0.13. So relative risk reduction was 87%. So in the 5 placebo arm, there is 5.3% of those patients who had been who needs hospitalization, or death, but in the remdesivir arm, it is only 0.7%. Now, as we are talking about Omicron and outpatient therapeutics, so as already we had discussed, the spike protein is the area where the mutations happening. So almost 32 mutations happen. So we need some small molecule that target the SARS-CoV-2 replication. So the antivirals which target the SARS-CoV-2 replicase, that could be a better option. And there are some data from cell cultures which suggest nirmatrelvir, ritonavir, molnupiravir, and this remdesivir, they are retaining or preserving activity, anti-SARS-CoV-2 activity against Omicron. And there is a very interesting thought that combining both, that means molnupiravir and the nirmatrelvir ritonavir combination, if we can combine both them, that could give us some synergistic result. So we need more research on this area, of course. So now, if we just have some summary slides like from all the trials recently published on molecules which are still approved, or we can say still present in the guideline in US NIH guideline, then we will find the nirmatrelvir ritonavir combination, sotrovimab and remdesivir, and finally the molnupiravir. So what are the data that suggest, if we just try to dissect all the trial? So for nirmatrelvir ritonavir combination, if we just see the efficacy parameters, there is a 88% relative risk reduction. The absolute risk in which is in the placebo group was 6.3%, and in case of nirmatrelvir ritonavir group, it is only 0.8%, who requires hospitalizations or death. So number need to treat is 18 here. But for sotrovimab, again it is 85% relative risk reduction. In placebo group, the absolute risk was 7%, which becomes 1% in the sotrovimab group, and here the NNT is 17. The remdesivir, from the PINETREE trial, what we found, the relative risk reduction was almost 75%, and the absolute risk was 5.3% in placebo arm, whereas only 0.7% in remdesivir arm. And the number need to treat analysis that suggests it is only 22. But for molnupiravir, which is available in India, the relative risk reduction is 30% only. The absolute risk in molnupiravir arm is 9.7%. Sorry, the placebo arm, it is 9.7%, which becomes 6.8% in the molnupiravir arm. So number need to treat is here little bit high, and we all know that, though it is not right to compare all the trials like this, but if the number need to treat is less, that means that particular drug has more efficacy. But as the time of study is different, the area of the study is different, we cannot just comment like this drug is better or this drug is less efficacious or more efficacious. So what are the pros? The combinations, it is highly efficacious, no doubt, oral regimen, and also ritonavir is safe in pregnancy. But what are the cons for nirmatrelvir ritonavir? They had a potential for different adverse drug-drug interactions, and we need to be cautious. For sotrovimab, pros are, again, it is highly efficacious, safe in pregnancy, and no drug-drug interaction. But again, as we are talking about Omicron and their variants, how much it will be effective for next variant, that is a question mark. And cons is obviously it requires IV infusion followed by 1 hour of observation for any infusion related reactions happening or not, but it is quite a safe drug. And also there are studies are conducted to see the efficacy of intramuscular sotrovimab, and which is almost non-inferior to intravenous sotrovimab. So if that is approved, then these cons can be eliminated if the intramuscular sotrovimab is approved by US FDA. Now coming to remdesivir, again, it is highly efficacious, studied in pregnancy without not that much concerns, and there is no drug-drug interactions. But the cons is it requires 3 consecutive day IV infusion. So that is a definite concern. Now coming to Molnupiravir, it is little bit less efficacious compared to the other molecules, but it is an oral regimen, that is the pros, and there are very less drug-drug interaction. But what are the cons? The low efficacy, mutagenicity concern, that is an important one, and it is totally not recommended in pregnancy and children. Now this is totally from my perspective, I am making this. If I have these 4 drugs, then this nirmatrelvir ritonavir could be my first choice, followed by sotrovimab, then remdesivir, 3rd choice, and molnupiravir is 4th choice. But unfortunately in India, we don't have these other 3 molecules. We have only molnupiravir. So whether it is our regulators' duty to help us to get molecules which is approved by, or though that is a approval under restricted use authorization by NIH or USA or European EMA, and also in the Australia. So this should be our appeal to our regulators to help us to get these drugs. It is not always possible to generate data in our country for all these drugs. Sometimes the data from our Western populations also could be could help us to understand their efficacy. We can get restricted use authorization, followed by the industry, the respective industry should do a detailed phase 4 trial or some good quality observational studies. So outpatient treatment options for COVID-19, if we have all these 4 drugs, the nirmatrelvir ritonavir combination, if there is no patient is not on any interacting medication, obviously patient is on interacting medications, we need to choose other therapies if those interacting medicines could not be stopped. And it is important to note this timeline: as soon as possible and within 5 days of symptoms onset. Then coming to sotrovimab, if the patient is on interacting medications or able to come to healthcare facility, then we can use this, and the timeline is little bit broadened up to 10 days. So as soon as possible and within 10 days of symptoms onset. So this is also true for casirivimab, imdevimab. But casirivimab, imdevimab, why we are not talking? It's poor efficacy against Omicron. Now talking about remdesivir, if the patient is already in healthcare facility, maybe the patient is admitted for some cataract surgery or some other complications like that, and patient found to be COVID-19 positive. So remdesivir could be a better choice. Or patient has a home infusion service, or we can arrange this type of facility, this home infusion service. We can use this drug. But again, the 7 days is the lag period. beyond 7 days, it will not act. So as soon as possible and within 7 days of symptoms onset. Finally, Molnupiravir, if the patient not able to be treated with above options. So in India, we don't have any other options. So we can choose Molnupiravir, but the patient should not be pregnant, or we also need to consider that mutagenicity potential, and as soon as possible and within 5 days. So here also, like Nirmatrelvir ritonavir combination, the lag time is 5 days. Beyond 5 days of symptoms onset, we should not use this Molnupiravir. So this is a living guideline. You can see, as we talked about, that change is only constant. So guideline is continuously changing. And for that also, the WHO in BMJ journal, they are publishing in periodic interval their guidelines. So this is the latest one, the 12th February 2022. And as of now, these are the molecules. They got some evidences with this type of molecules. And here you can see a very interesting molecule is in the picture, that is fluvoxamine. We know that fluvoxamine is an antidepressant drug, and again very recently, 4 or 5 months back, this trial was published with fluvoxamine. So it was found that clinically important absolute risk reduction of 5% and 32% of relative risk reduction on the primary outcome of hospitalization, that is defined as either retention in a COVID-19 emergency setting or transfer to tertiary hospital due to COVID-19, consequent on administration of fluvoxamine for 10 days. So there is a 32% relative risk reduction with this fluvoxamine molecule. Now coming to different guidelines. So first of all, as we are talking about living guideline, this is the 11th February or 12th February guideline that is published in BMJ. So they are telling us to divide the COVID-19 disease in 3 groups. One is non-severe, that means absence of signs of severe or critical disease. Who are the severe or critical disease? That means the oxygen saturation is less than 90% on room air. Signs of pneumonia, signs of severe respiratory distress, they are severe disease. Critical means requires life-sustaining treatment, or the ARDS patients or sepsis or septic shock patients. So for non-severe patients, the interventions are nothing as a strong recommendation is favor. So this box is empty box. Yes, the severe and critical patients, there is a role of corticosteroids, ILC receptor blockers, or persetinib. Again, this is important, this or is important. And they are strongly recommended. We are not going to discuss about those molecules, as we are talking about only these non-severe cases, the mild to moderate COVID patients or OPD-based COVID-19 therapeutics today. So here you can see weak or conditional recommendation in favor of only 2 molecules they give, the casirivimab, imtevimab, and sotrovimab. But as of now, the casirivimab, imtevimab combination has a very poor data on Omicron. So sotrovimab is a good option. There are some studies with casirivimab, imtevimab, which found that it could be beneficial if we also use it lately. And this is very important to note, for non-severe cases, we should not use corticosteroids. So weak or conditional recommendation against these corticosteroids. In this group, they are also telling about that remdesivir, it is not approved for non-severe cases, but I think the results of PINE trial, that is quite impressive and that can change the guideline. But ivermectin should only considered in context of clinical trial, and convalescent plasma also should only considered in context of clinical trial. So again, strong recommendation against. So which are the drugs? Strong recommendation against strong recommendation. Convalescent plasma use in non-severe cases. There is a strong recommendation against hydroxychloroquine, strong recommendation against, and lopinavir, ritonavir, strong recommendation against. So this is very important. And I think after the very recently published data on Paxlovid, sotrovimab, remdesivir in non-hospitalized patients, and molnupiravir, they are they will come up in this guideline. And if this is the guideline by NIH, you can see already we had discussed this also. The patients who does not require hospitalization or supplemental oxygenation, we can consider these molecules. Symptomatic management for all, and antiviral management for those who are at high risk of progressing to severe COVID-19. And this is according to the preference based on the efficacy and convenience of use. So this is matching with our first, second, third, fourth. Like first is ritonavir boosted nirmatrelvir, that is Paxlovid. Second choice is sotrovimab. Third choice is intravenous remdesivir for 3 days, and fourth choice is molnupiravir. And this panel recommends against the use of dexamethasone or any forms of systemic corticosteroids in the absence of any other indication in this group. So this is very important. And what is again I want to mention that our regulators should think about the other molecules like ritonavir boosted nirmatrelvir, sotrovimab, and remdesivir as an outpatient basis use. Obviously, the access is an important question and we need to address this holistically. Now, if we go through the Indian guideline, so as of 14/1/2022, there is no drug for or no antiviral is approved for mild disease. Even moderate disease, there is no antiviral is mentioned. Only there is conditional or we can say restricted use authorization to remdesivir, and that is an anti-inflammatory therapy with tocilizumab. The mild patients, therapeutics, COVID-19 therapeutics, as we are discussing today, we know that results of STOIC trial, the fascinating result of STOIC trial, which help us to understand the importance of inhalational budesonide of around 800 microgram twice daily for maybe 5 days, like that. That is recommended also in the ICMR guideline for those patients who are mild patients. So in Indian guideline, the ICMR guideline, they are dividing into 3 groups: mild, moderate, and severe. Mild means only the upper respiratory tract symptoms and or fever without shortness of breath or hypoxia. So if it is hypoxia, that means between saturation 90 to 93%, and the respiratory rate is more than 24, then that is the moderate disease. And in case of severe disease means there is tachypnea, respiratory rate more than 30, and the saturation is below 90. So as of now, there is no antiviral that is recommended in the ICMR guideline. The remdesivir, that is an EUA or off-label use. For those, still it is written like that 10 days of onset of symptoms in those having moderate to severe disease requiring supplemental oxygen, but who are not on IMP or ECMO. So again, our appeal to our regulators will be to consider remdesivir a little bit early to get its optimum effect. As we are talking about viral phase of COVID-19, it is always better to start early the antiviral without waiting for the worsening of the patient. If we want to start remdesivir, it is always better to start early. Specifically, the fascinating result from PINETREE Trial, where they used remdesivir early and 3 days therapy in those patients who were not hospitalized. So there is almost at around more than 70% or almost 80% relative risk reduction compared to placebo. So what should be our future directions in outpatient COVID-19 therapy? We need to answer few questions in future. That is, what is the benefit of therapies in lower risk patient? So we talked about high risk patient. Now lower risk patients, is these therapies are at all required? That means already the patient has vaccinated already and patient is infected with Omicron. So is it required at all? Next question, will monotherapy select for viral resistance? And what is the role of combination therapy? Specifically when we are talking about severely immunocompromised patients. There was one author who told that immunocompromised patients acts like a mutation factory of that SARS-CoV-2. So whether we should be more focused and use combination antivirals in patients who has immunocompromised state and suffered from SARS-CoV-2. That question needs to be answered. Should these oral therapies, monoclonal antibodies, be used in hospitalized patients also? So only if patient admitted for non-COVID reasons and otherwise meets the emergency use authorization criteria, maybe patient has a history of cerebrovascular accident, or patient admitted for cataract surgery, so ultimately found to be SARS-CoV-2 positive. There we are using this MAP cocktail. So again, we need to explore this, whether we also need to give in those group of patients who are admitted for COVID also in the hospitals due to some exacerbations. There are some studies with casirivimab, imtevimab in hospital patients. But as we are talking again and again, the mutation of the spike protein, it is important to develop monoclonal antibody cocktails considering the change in that particular spike proteins. We should have more specific monoclonal antibodies against this SARS-CoV-2. Otherwise, the older one, there is lots of change happen in Omicron, and even the new strain of Omicron, the specific change that happened, that also leads to resistance of this SARS-CoV-2 against sotrovimab also. And another important question that requires answer, that is the long COVID, whether this antiviral therapy is going to help in prevention of long COVID. That also need to be answered. And I think we can take these participants of different RCTs conducted, and we can follow up them, and we will find the answer. Hopefully the investigator will do this and give us the answer maybe after 6 months or 9 months, like that. But this is very important. So there is no doubt in that change is the only constant. And this COVID-19 pandemic teaches us repeatedly that change is the only constant. And in our Gita, there is also Lord Krishna taught us that basangsi jirnani jatha vihaya navani ghnati naroparani tatha sharirani vihaya jirna tatha sharirani vihaya jirnanna nayani sangyati navani dehi. So also told regarding this, the change is only constant. But this is important. This chapter is very important. How we can prevent the fast decline of stock of health. How we can square the curve with compression of the morbidity. So death is inevitable, but how we can do that? For that, we need to strengthen our innate immunity, and our innate immunity needs healthy behaviors. So don't smoke, be physically active, eat a healthy diet, maintain a healthy weight, and get enough sleep. These 5 mantras, if we follow, we have a good innate immune system, and that is actually constant thing. It is nothing to be changed. This mantra is fixed. If we have this type of healthy behaviors, our innate immunity will be strengthened, and that can fight against this virus. Even this virus will have mutations. So that is why we talked about something which is constant, that is jatasya hi dhruvo mrityu dhruvang janma mritasya cha tasmat pariharjathe na tvang shuchitu maharshashi. So there is something which is constant, and for that I end here with giving emphasis on how to strengthen our innate immune system that can help us to fight against this SARS-CoV-2. With that, I just want to thank you all for your patient hearing. I just want to request you all, if you have any question or comment, you can put in the chat box so that we can address those questions. Thank you. Thank you once again. Namaskar.